Welcome to a Shot in the Arm podcast. I'm Ben Plumley and I'm your host, and this is a podcast about global health and human rights. Now, this is the fourth season of a Shot in the Arm podcast, and we produce this in partnership with the Bay Area Global Health Alliance. You can find out more about them at www.bayareaglobalhealth.org. Now, in this season, we're going to be looking at the future of responding to Covid-19. And last week, our signature opening interview was with Dr. Tony Fauci from NIAID. And we looked at all the scientific and behavioral science that's going in massive investment to try and turn this thing around. But this week, we're going to go much closer to the ground and meet with experts who are helping frontline workers right now respond and using some of the tried and tested public health responses that are there. So, with no further ado, it is my honour to welcome the first, Dr. Marta Induni, who is the Director of Tracing Health at PHI, the Public Health Institute. Marta, welcome to a Shot in the Arm podcast.
Thank you, Ben. It's great to be here. I appreciate it.
Thank you. Our next guest is Dr. Nick Moss, who is the Interim County Health Officer for Alameda County. Nick, welcome to the show.
Thanks, Ben. Pleasure to be here.
And last and certainly not least, my friend and colleague, Dr. Mike Reed, who is Assistant Professor of HIV, Infectious Disease and Global Health at the University of California in San Francisco. Welcome to the show, Mike.
Thanks, Ben. Lovely to be with you.
So, look, this week we've been talking all about, warp speed vaccines, therapeutics getting fast-track FDA approval. We've been talking about antibody cocktails, rapid tests, and yet the bulk of our response to COVID-19 has centered around tried and tested approaches, namely the contact testing and tracing. It's a long, hard slog, but it's fundamental to containing a pandemic like COVID-19. Marta, if I could kick off with the first question for you. As I say, test and trace, contact tracing, it is an established utensil in our toolkit. You've been working with PHI to implement this across the Pacific Northwest and now into the Central Valleys.
Right.
How has it been to adapt that tool for the needs of this particular pandemic?
Well, it's a good question, Ben. It is a tried and true method. It's been around for over 100 years, and whether people realize it or not, it's around our day-to-day, even before COVID-19. Diseases, or communicable diseases such as STDs, HIV, TB, tuberculosis, all those, undergo extensive contact tracing when a case comes up. Part of the issue with the COVID-19 tracing is just the sheer quantity of it. Also, it's very unpredictable in how it's working. Some people are very susceptible. Some people get more virus than others. People present symptoms differently. People definitely have different health outcomes. And so I believe we are doing a lot of adaptations right now to the contact tracing as a concept. And, it's still being developed. COVID-19 will be around for many months, maybe years, and so we will get better at this piece. But
Well, I suppose to some degree we're still all thinking on our feet as we try and understand what is something much more than a respiratory disease. Nick, if I could come to you. You lead not only the HIV work, which is how I think we all know you so well in Alameda County, but you're now leading the COVID response. And there's Alameda County across the bay from San Francisco, often thought of as the shadow sister. You have Oakland, Berkeley going out to Livermore. San Francisco's had about 12,000 cases of COVID. Alameda County has double that, 24,000. What's going on in Oakland and the East Bay?
Well, first of all, Ben, I think, of course, San Francisco has got a major medical center, a great public health department. They do great work. They've certainly been impacted by COVID. Around our department, we don't think of ourselves so much in terms of our relationship to San Francisco. We like to think of ourselves as standing alone with our unique challenges and achievements. And, we have about twice as many total cases as you've noted, but we also have about twice as many residents in Alameda County. We're extremely diverse. We have also, I think, probably a different workforce in terms of the number of lower income essential workers who reside in Alameda County. And so they might work in a different county, but if they get sick, that counts in, towards our total. And so I think that there's nothing surprising about what you see about the distribution of cases. And I'd also point out that, both San Francisco and Alameda County, as well as the Bay Area as a region, have done fairly well in terms of controlling the pandemic relative to other places. We've certainly had our share of impact, many deaths that we wish we would have been able to prevent. But I think that we often want to point as much to our shared successes as to differences in terms of what's playing out in the East Bay versus San Francisco. And the impact of COVID has been disproportionately felt in communities that we have that are broadly represented in Alameda County, and so much of the story has been how we work and support those communities through this, while also looking at the impact on the whole county.
Yeah, and the Bay Area, say, compared down the road to Los Angeles, Greater Los Angeles, and of course to cities in the on the East Coast, we've collectively done pretty well. Mike, I'd love to turn to you now, because UCSF has helped San Francisco County in establishing its test and trace program. You've helped the Navajo Nation, and you've also just come back from supporting Guam in setting up its test and trace program. What are you seeing there in terms of how you have to adapt and think on your feet to create a program that is culturally sensitive?
Yeah, I think two things come to mind, Ben. First is the need for speed. The need to rapidly implement a program where one didn't exist posed challenges. And that included task shifting responsibilities that were previously performed by public health department professionals to furloughed civil servants, librarians, and now more recently community health workers. But not only speed in scaling up programs, but also in responding to the epidemiological challenge in front, and doing contact tracing well requires efficiently reaching people as quickly as possible. So I think need for speed is one of the things that we've had to adapt this intervention for. The other is, and you alluded to this in your question, is the importance of an inclusive response. Contact tracing is not a silver bullet. If you can't support people to safely isolate or quarantine once you reach them, then the work of the contact tracer is only half done. And so it has to happen in tandem with supportive wraparound services, particularly for those communities that have been most impacted. So I think those are the two things that I think of that are particularly challenging about this epidemic as it relates to contact tracing.
Yeah, I completely agree, and I want to come back to this in more detail in a second. I suppose at the start of the pandemic, in an abundance of solidarity, we said COVID-19 affects everyone in the same way. But here we are 10 months on, and we're seeing that, in fact, different communities, particularly Black and brown communities, are being very differently affected. And Marta, I wondered, what is causing this? Is it the sort of traditional disparities in health, fear of health authorities, systemic racism? What do you see is going on?
Right, it's all of the above. It's I hate to say perfect storm. It's a perfectly horrible storm. But we do see years, centuries of systemic racism, excluding people from appropriate health care, access, and treatments as one. We also see a class of what we've now called essential workers, right? These are people who are service employees who help us get through our everyday, but we're talking about Black and brown people disproportionately affected, working side by side with other people in close proximity. They don't have the workplace protections. We've seen this in food processing plants with our Latino brothers and sisters who are working in there. They're scared to take precautions. They don't want to be fired, for example. There's a lot of stigma around being sick. There's a lot of misunderstanding around even household compositions. When you've got people who are 12 to a home, 16 to a home, entire families sharing rooms. The idea of preventing the spread of the disease takes on a different set of measures that we need to implement. So all this comes together, and then we have people who are more likely to be turned away from testing. Again, our Black and brown people in California, residents of California, depending on their healthcare systems, may get different treatment. And so, we see the numbers, and we see the much higher disproportion, not only of poor health outcomes, but of fatality also. So,
yeah. And I guess, Nick, that's something that you've particularly seen in Alameda County. If I understand the data correctly, Alameda's 24,000 or so infections, about half of those are in the Latinx communities. How has Alameda County responded to that and tried to provide support to them? And you're on mute, Nick.
Yeah, it wouldn't be a call like this without that happening at least once. It became evident really early on that as you said, it was not impacting everybody equally, but in fact that our communities of color, not just in Alameda County, but around the country, were disproportionately impacted. And what we have seen play out in Alameda County is that communities where people were working in essential industries or industries that we brought back to activity earlier in the shelter-in-place process, where people didn't have the ability to distance themselves from their coworkers. They didn't have sick leave. They didn't feel comfortable staying home if they were sick or exposed. And where at that time, and it's still an issue. I think we've done much better, but employers and workers and the health department weren't in as good a position to help ensure that the right safety measures were in place, face coverings and distance and things like that. And so, these communities where workers were exposed early on in the pandemic, despite our shelter-in-place restrictions, they are largely made up of workers from communities of color. And then also we have people, and Marta, was making this point, but these are people. The Bay Area is a very difficult place to find housing. These families do not have huge amounts of resources. They're working in lower paying industries, and we have many people living under the same roof. We know COVID spreads very easily in those circumstances. And so, really this created and exacerbated these disparities from early on. I think in our recent data, we've seen a decrease in some of these disparities in our rates in Alameda County as overall rates have fallen. But I fear that as rates climb again, we'll again see these disparities in case rates for these same reasons, despite measures that we're trying to put in place.
I mean, Nick, just to stay with you for one more question, a key thing that has come up, and it applies to San Francisco as well, is how to support the homeless communities in an age of COVID. and Alameda did a great job of providing hotel accommodation to people who were affected by homelessness. And yet, one of the local nonprofits I'm heavily involved in found that people didn't want to leave their encampments for fear that their very few material possessions might be put at risk or be stolen. And so how did the county evolve its response to meet the needs of that particular community?
Yeah, this was a priority early on. As we were learning more about COVID, we knew we had this very vulnerable community, a community that is subject to other types of public health threats and many other challenges and barriers. And we did develop a robust partnership both with our own county healthcare for the homeless team and the non-governmental agencies that work in this space to both have good guidelines and as many resources as we could line up as possible. And critically, those hotel resources that you mentioned, with the support of the state of California and our city partners across Alameda County. And so I will say that there certainly are, it's not the right solution for everybody. Not everybody who might benefit from it wants to go to a hotel room. We have rooms available for people who are sick, who are exposed, and need a safe place to quarantine, and also for people who are medically fragile or at risk for severe disease outcomes. So all of those were available. We are transitioning some of those to permanent housing. So we're using this as a launchpad for permanent housing. So a lot to celebrate there. But you're right, it's not the right solution for everybody. And it meant that we also had to find ways to support people who wanted to remain in place, make sure that they had everything they could to do that as safely as possible. I'd say that a couple points. First of all, the pandemic has not impacted in Alameda County, that community, as much as we had initially feared. I think in part because of these measures and because there's some fairly robust efforts directed at that community. And also, the impact of transmission in indoor settings has only become more clear as we've gone along. But I agree, it's a good sign that we can create these resources, but you really have to match the resources to the particular need of the population. Another thing along these lines, we extended those hotel rooms to people who are at risk of homelessness or lived in crowded households. And some people didn't want to leave their household because, the importance of staying with your family when ill, family support when ill. And so, there are limitations to how we can apply some of these resources, and we need to find other solutions to some of these challenges.
Yeah, I mean, we're learning as we go. As we go. I mean, Mike, you and I have had this conversation, and it's something I raised with Tony Fauci last week. The CDC guidelines, after you've contacted someone and said to them that they may well have been exposed to COVID by someone who had identified them as one of their contacts, there's very little that we actually offer them in the CDC guidelines beyond telling them to self-isolate for a period of time. And for many folks, that's very difficult. What have you done and what have you seen that is helping perhaps provide more resources to people while they isolate?
Sure. So, I mean, I can speak from the San Francisco example, which is the one I'm most familiar with from helping to run their program. And we have, like Alameda, a broad range of resources that are available to support people to safely isolate. I think most notably in San Francisco, we have the Right to Recover funds, which provides laboratory confirmed COVID cases with $1,285 to safely isolate for 2 weeks, which works out to be about minimum wage for someone for that period of time, and that is available regardless of immigration status or citizenship. I think that kind of resource is crucial, particularly if we want to ensure that those vulnerable communities most impacted by COVID are able to fulfill the responsibilities of isolating if they're a case or quarantining if they're a contact. In addition, again, in San Francisco, we provide food delivery for folks that don't have a means of accessing food. Prescription drugs can be delivered to your home. You can even get your pet walked if that's appropriate. I think the thing to highlight here, though, is that San Francisco is a relatively wealthy jurisdiction, and I don't think it's the case that all counties are able to offer that same level of care. But certainly, I think it's a model that should be replicated if we're serious about scaling contact tracing. Because as I said before, just reaching people and telling them you've got to stay at home isn't enough unless you're able to support them to fulfill that obligation effectively.
Yeah, I completely agree. And Marta, I mean, in the populations you've worked with, and now again, here you are coming into the Central Valleys, a lot of what Mike has described may not be possible. And there's also the question of how all of this impacts the mental health of people affected. What tools are you seeing being utilized in the more marginalized populations?
Well, it not, as you're mentioning, not every tool fits every situation. We do know that there are trust issues in the communities that we're working with. When you have an administration that has been quite negative, especially against Hispanic and Latino populations, there is an element of, why are you calling me? Why are you asking me to do this? No, I won't leave my family, right? And so some of those tools are, all right, we need household prevention measures for people to either quarantine or isolate together. Some counties have been, in their CARES funding and their congressional funding, have set aside money for to help people, support people with rent assistance, with food assistance. And sometimes it's just a matter of problem solving. Who in the community can you contact to deliver your work, your groceries or medicines or whatever you might need. So, is it realistic that everyone's going to be helped with these tools? No. And we also know that there's cultural disagreements on even the existence of COVID-19, and so those messages are very hard to combat because people just reinforce their own views, and so we are dealing with segments of the populations that are challenges. One thing we teach our staff is we have everyone go through trauma-informed training. And this is, we are working with traumatized communities. And our own contact tracers are from those communities, and we need to recognize that they are also working with challenges. And so we need to increase our empathy. And yes, we're going to call cranky people. We're going to call people resistant to what we're saying. And we need to keep in mind also, they're sick. We're asking them for a sacrifice, right? And they don't know if they won't show up to work that they'll be fired. And then, so what's worse, going to work sick or being fired and losing your home? And so these are the questions people are dealing with on a daily basis. And I do hope counties and, with federal funding or in other measures can step up that day-to-day support that when we're asking people to isolate or quarantine, that really makes the difference between success and failure.
And I fell for it myself, speaking without the unmuting myself. Oh, I'm going to be in trouble. But I think you're absolutely right, Marta. This is the make or break of whether we are successful, and it's it also has to be human rights ramifications. If you look at the HIV movement, that to some degree has helped influence and drive the response that we've seen so far. There's been a real kick, if you like, or a pushback against what are seen to be perhaps mandatory measures. So isolating and restricting access to basic essential services are things that many in the community are really pushing back against. And it's been really interesting to me that hasn't been such a big part of the debate, that the communities that we are talking to, individuals and groups, are saying, okay, well, what is it that we need to do, and what is it the help that we need in order to achieve that? And Nick, perhaps I could come to you on this. Have you seen in Alameda people pushing back against, get out of my face, get out of this, we do not need your intrusion, thank you very much?
Well, yeah, there's all kinds of pushback, certainly, although overall, I think in Alameda County, our residents, our businesses, community members have really actually done a wonderful job of putting up with the restrictions and things that we've asked of them. And that is really the story for any successes that we have had are due to those sacrifices on their part. But certainly, I would echo what Marta was saying about the experience, of working on the ground in terms of case investigation, contact tracing, and what you hear from people, or what you don't hear because they simply don't pick up the phone and speak to you. And due to the just sheer numbers of cases and contacts we're talking about here, this isn't a situation where we're able to go knock on everyone's door. In certain situations, we have done that, especially early on. But generally speaking, we just aren't reaching everybody because people know that we're going to tell them that they need to stay home, and that threatens their livelihood, or there are other trust or concerns that come up. And so it's as much that as anything. It's that people have to do what they have to do, what they see they need to do for their own lives and their own families. And they, there is concern that us asking them to isolate or quarantine is going to interfere with that. And then more broadly with, our shelter in place restrictions, which, we're in the fortunate position to be able to start rolling back some of those slowly. Although I do expect at some point we will see another surge in cases, and we will probably need to revisit some of that. That's the other place where people, really question what makes the most sense. And it's incumbent upon us in public health to make sure we're looking at all the available evidence, trying to make as good, sound, defensible policy decisions as possible, and really work to get things open as quick as we can. And I think in general in Alameda County, relative to some other parts of the country, people have been tolerant and accepting of that. But I certainly spend a lot of my days, talking with various, groups, individuals, stakeholders, hearing from people about really wondering why we're making setting the policies that we are. Usually I think people have been accepting in Alameda County, and that's been very helpful.
So I guess this leads us to the question of, where do we go from here? Contact tracing is not going to capture the entire population of people who have been exposed, not necessarily infected. It's going to be one of the things we can do. And I would love to get from all of you your sense of whether this is now the new normal that we're going to have to accept and adapt to, or do you think that maybe in 6 months or a year or maybe even later that we might return to some sort of pre-COVID freedom that we had? And Mike, maybe I could start with you. I can see you just nodding vigorously there.
I mean, I think as an optimist, I think there is an opportunity in this moment with resources to transform the healthcare system in a positive way, so that we don't go back to how it was in 2019. To your question about whether we'll be doing contact tracing for the foreseeable future, my guess is we probably will be doing it until there's widespread uptake of a vaccine, and really a vaccine that can prevent transmission. I imagine that's a topic for another podcast. And in the meantime, I think where I would look for optimism is in who that contact tracing workforce can be. And so both in Alameda and in San Francisco, we're mobilizing a workforce of community-based organizations who are embedded in those communities, who understand the lived realities of those communities, and can also support those communities in other health promotion activities beyond COVID-19. And so in the near future, that means like influenza vaccine uptake. But looking to the future, could this workforce transform how we think about blood pressure control and other things? I mean, I know that's beyond the purview of this session, but I think there is an opportunity to really reimagine what public health infrastructure looks like in California and the US, and maybe that is now.
Yeah, I think that's absolutely right, and it's a wonderful, enthusiastic note, Mike. Nick, as you deal with a county that has huge disparities, what do you see over the next few years? How is this going to play out, do you think?
Well, I really appreciate Mike's optimism, and I do. It's not just about getting back to something like what normal life was before, but taking the lessons learned and trying to fix some of the problems that contributed in the first place. And I share that optimism. I do believe we'll get to that place. Some things may stay with us, and hopefully part of that is a more robust public health infrastructure, but also a healthcare system more broadly that has fewer gaps and meets the access needs of some of these communities. This might be too pie in the sky, but maybe an economic system that's maybe a little less exploitative, and we have a little bit better protections for workers so that when these things happen, they can take some sick leave, they can stay home for a while, and they can go back and get their job back. And then I think in the short term, we really do need to double down on these efforts that Mike described, partnering with the communities, community-based organizations embedded in these communities that really know how to connect with people, because COVID's not going away in the short term. And I think a lot of the things that set up the disparities that we have seen thus far are not going to melt away either. And so it's really our responsibility to try to create better short-term policies to avert and prevent those as much as possible.
Thank you, Nick. And I guess that's an also quite an upbeat sense. This is an opportunity. Marta, the last words to you. Do you see opportunities here, and how can we grab them, both to enhance our response to COVID, but improve access to basic, perhaps universal healthcare for folks who may have been, who've fallen through the net prior to this?
Absolutely. And unlike Dr. Mike, I'm not really an optimist, but I do see opportunities that lie ahead. One thing is I'm very proud of the public health and allied health communities and how they are looking at disparities and inequities in care, in outcomes, and in fatalities, how we treat families in different ways. People that are on the edge because of COVID are on the edge, period. And so we have an opportunity to get people connected to social service, human service programs that they may have shied away from before. So all those opportunities are at hand. I've never heard more conversations around racism and really people with, I am an immigrant from South America. I'm a native Argentinian. And I know that I have colleagues and friends, and we know refugees who've been trained in other countries in the medical fields. Let's bring them into the fold. Let's have them contribute also in a way that is meaningful. There are many opportunities to right a lot of wrongs in our society and to level privilege across multiple partners. So those are the opportunities I see. As far as illness, you're right. We're gonna be dealing with contact tracing for a long time. We need to step up our test to reporting timeline. There's an opportunity there for improved electronic reporting, all sorts of things that we will. I'm hopeful we will get a handle on those in the next few months. So, never give me the last word, because I'll take the time.
No, anytime. And all three of you are most welcome to come back. And in fact, we would love to be able to just check in with you. I mean, we're coming into, what was it Joe Biden said, the dark winter months? Well, the slightly cooler winter months for us in the Bay Area. But this has been a fascinating conversation, and I really do appreciate, the upbeat, looking for the opportunities that this is teaching us. And I think it's a welcome break from all the dystopian binge watching I've been doing. So with that, I just want to say, Dr. Marta, Dr. Nick, Dr. Mike, thank you so much for being on A Shot in the Arm podcast. We really appreciate all the hard work you're doing, and anything that we can do to continue to support it and, draw a light onto it, we'd be really happy to do. So thank you.
Thank you so much. A real honor. Thank you, gentlemen.
Thank you, Ben.
Yeah.
Thank you.
Okay, well, that's it for this episode. Thank you all very much for joining us. Thank you to our guests. Again, a sort of an upbeat end to a conversation on contact tracing. Well, I wasn't expecting that. A big thank you to Sarah Anderson and all our colleagues at the Bay Area Global Health Alliance. A huge thank you to our director and producer, Erica Spera from Newsdoc Media. Doing these kind of live stream recordings is tough, and we're learning as we're going. So thank you for bearing with us. And then, of course, a final big thank you to you. As always, if you have any comments or suggestions about this or any other episode, we would love to hear from you. So it just remains for me to say, have a safe, have a healthy week, and don't forget to wear your mask.